You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Welcome to Obesity Chronicles, a novel perspective. My name is Robert Kushner, and I'm professor of medicine and medical education at Northwestern University Feinberg School of Medicine in Chicago, Illinois. This program is intended for healthcare professionals. The information presented in this podcast is aligned with the views and opinions of the speakers and is sponsored by Novonordisk. The speakers have been compensated by Novonordisk for their participation in this program. This podcast is not to be used as medical advice and is intended for educational purposes only. It is not approved for continuing medical education credits. In today's podcast titled Moving Toward Better Metrics, Can We Do Better Than BMI? We will review BMI, exploring its use as a measure of adiposity, discuss options for measuring adiposity, like anthropometrics and body composition measurements, and discuss their relevance in clinical practice. Highlight the importance of analyzing body composition for further assessment of future health risks, and discuss emerging tools for measuring adiposity, like waist-height ratio and bioimpedance. I am pleased to be joined today by Dr. Jamy Ard and Dr. Jaime Almandoz. Dr. Ard and Almandoz, could you please introduce yourselves to our audience?
Hi, I'm Jamy Ard. I'm professor of epidemiology and prevention at Wake Forest School of Medicine in Winston-Salem, North Carolina, and I co-direct the Wake Forest Baptist Health Weight Management Center and lead our medical weight management program.
Hi, I'm Jaime Almandoz. I'm associate professor of medicine in the Division of Endocrinology at University of Texas Southwestern Medical Center in Dallas, where I'm also medical director for the Weight Wellness Obesity Medicine program.
Welcome, Jamy Ard and Jaime Almandoz. Today, we're tackling a topic that's been generating a lot of buzz in the medical community. Is BMI, or body mass index, truly the best tool for diagnosing obesity? It's a question that's been debated for years, and for good reason. Although BMI is easy to calculate and widely used, it is not intended to be a one-and-done measurement to diagnose obesity. It should be used as a screening tool alongside a comprehensive assessment of the individual patient. There are limitations to using BMI as a measure of adiposity, and as healthcare professionals, we should be aware of these limitations. This topic will likely continue to evolve as we deepen our understanding of this multifactorial disease. In early 2025, the Lancet Diabetes and Endocrinology Commission published a statement proposing a new set of criteria for defining and diagnosing clinical obesity, which raised questions about the diagnostic utility of BMI. However, it is important to note that this publication is part of an ongoing discussion within the medical community. Despite all this, we've relied on BMI for quite some time, and is certainly a readily available metric. However, like any tool, it is important to understand its strengths and potential drawbacks. Jamy Ard, can you start us off by outlining some of the advantages of using BMI?
Well, Bob, as you know, BMI is a measure of weight relative to height. It's calculated by taking weight in kilograms and dividing it by height in meters squared. For those of us who don't want to do the math, we don't need to. There are several online calculators available, including one from the CDC. And in fact, most of our electronic medical record systems will calculate this for us. As you said, Bob, BMI has been used as a screening tool for a long time. It is a long accepted proxy for adiposity that is widely recommended, simple, and practical to use. It's quick, it's easy to calculate, low cost, and reproducible. So it works well as an initial screening tool. It helps categorize if a person has underweight, normal or healthy weight, overweight, or obesity. And it's been widely used in both clinical practice and large-scale population health studies around the world. There has been extensive research to show that high BMI is associated with health outcomes, such as all-cause mortality and some comorbidities, including hypertension, dyslipidemia, and other chronic diseases.
Thank you, Dr. Ard. Now I'd like to review BMI categories because there are some important nuances, particularly the difference between BMI categories for adults versus adolescents, and also the different stages or severity of obesity, which are important to discuss. So, Jaime Almandoz, would you please walk us through the BMI categories in adults and adolescents?
Sure, Bob. Let's first discuss BMI classification for adults. An adult who has a BMI of less than 18.5 kilograms per meter squared would be considered underweight. If the BMI is 18.5 to less than 25, the adult is considered to be within healthy weight. Overweight in adults is considered a BMI of 25 to less than 30. And as you mentioned, there are different levels of obesity severity, and these are also categorized by BMI. Class 1 obesity is defined as a BMI of 30 to less than 35. Class 2 obesity is defined as a BMI of 35 to less than 40, and Class 3 obesity is defined as a BMI greater than or equal to 40. BMI categories are defined differently for children and adolescents to account for continued growth. BMI categories for these patients are based on BMI percentiles relative to others of the same sex and age rather than absolute BMI ranges. In this younger group, obesity is defined as a BMI range greater than or equal to the 95th percentile, and severe obesity is defined as greater than or equal to 120% of the 95th percentile, which would be equivalent to a BMI score of greater than or equal to 35 kilograms per meter squared in adults.
How do you both use BMI in your clinical practices?
From a clinical standpoint, one of the first things I emphasize to my patients is that achieving a, quote, normal BMI isn't always the goal. Many people know a normal BMI is below 25, and they may feel discouraged thinking that they can never reach that BMI. I reassure them that this isn't necessarily the goal. We often see some health improvements in patients well before they reach a BMI target of 25. Secondly, considering a patient's starting BMI also helps inform personalized weight management strategies. It provides context for associated health concerns and guides our approach to care. These are two key ways I use BMI in my clinical practice.
I agree with Dr. Ard's foundational points. To reiterate, in clinical practice, BMI should be a starting point, not the final answer. While a high BMI may warrant further evaluation, it doesn't automatically diagnose obesity or predict health outcomes or risks on its own. Clinicians should consider additional factors beyond the BMI number, such as waist circumference, body composition, and other metabolic markers to create a more personalized and effective care plan.
Clearly, you are both aligned, as am I, that while BMI is a tool we use frequently in clinical practice, it might not tell the whole story when it comes to assessing someone's weight and health. Dr. Ard, what are your thoughts on some of the potential drawbacks of using BMI as a measure of adiposity?
Bob, as you said, BMI alone doesn't provide a complete picture of an individual's weight and health. For example, it doesn't account for fat distribution or body composition, such as distinguishing between fat mass and lean mass or muscle and bone. Two individuals with the same BMI, based on height and weight, might have vastly different body compositions, one with more muscle, the other with a higher proportion of fat. Therefore, while their BMI are similar, their actual cardiometabolic risk may vary.
I agree. The 2016 American Association of Clinical Endocrinologists, American College of Endocrinology, or ACE Comprehensive Clinical Practice Guidelines for patients with obesity, explained that BMI alone is inadequate for obesity diagnosis, failing to capture the nuances of a patient's weight and health and potentially hindering effective medical care. According to the ACE guidelines, BMI should be used primarily as a screening tool as part of a comprehensive patient evaluation and often with other measurements of adiposity. The guideline also proposed a complication-centric approach where management strategies are guided by the presence and severity of weight-related complications. This paradigm is intended to prioritize the improvement of a patient's weight and health rather than achieving a target BMI. A consensus across medical societies of multiple disciplines, including the American Heart Association, American College of Cardiology, and Endocrine Society, also acknowledges the limitations of BMI and the need for a more comprehensive patient-centered evaluation. This also aligns with the International Obesity Collaborative Consensus Statement, which emphasizes that obesity care is about health, not weight. This statement, like to shift away from reliance on BMI, suggesting that considering weight and health, including weight-related comorbidities, is paramount, emphasizing a broader patient-centric approach. Other measurements of adiposity may be considered, including available anthrometric measurements like waist circumference, waist-to-height ratio, and waist-to-hip ratio. And I would add that when available, direct body fat measurements such as DEXA or bioimpedance may be used to assess the body fat percentage of a patient. Due to practicality, we frequently use waist circumference and an indirect but good indicator of visceral fat. Dr. Ard, could you explain to our listeners what visceral fat is and what the health implications of excess amounts of visceral fat are?
Sure. Visceral fat is the fat behind your abdominal muscles that surrounds the stomach, liver, intestines, and other organs. Some levels of visceral fat are healthy and necessary to help protect your organs. However, too much visceral fat can be harmful. Visceral fat is more metabolically active than subcutaneous fat and releases a higher amount of inflammatory factors. Excess visceral fat or visceral obesity is associated with several medical conditions, including metabolic syndrome, malignancies such as prostate, breast, and colorectal cancers, cardiovascular disease, as well as all-cause mortality.
Thank you. This is such an important point that despite one's BMI classifying them as normal weight or overweight, they can still be at a higher risk of developing metabolic diseases if they have high amounts of visceral fat.
Absolutely. That's one of the reasons why BMI alone can be misleading in terms of one's associated health risk. Someone with a higher proportion of visceral fat could have a normal BMI, but still face higher risk of developing metabolic diseases, while someone else, like an athlete with a high muscle mass and a high BMI, who is categorized as having obesity, could have a relatively lower health risk if their body composition includes more muscle and less fat.
I agree with Dr. Ard. BMI is a blunt tool. It's useful as a starting point, but we now know it's not enough on its own for a comprehensive assessment of an individual's weight and health. At our medical center, we serve a very diverse population, and we sometimes see patients whose obesity or associated health risks have gone unaddressed due to the inappropriate application of BMI criteria. This can happen in a couple of ways. We see patients with other cardiometabolic risk factors who haven't received appropriate health screening because they have not had an official obesity diagnosis. On the other hand, some individuals have experienced weight-related stigma and negative interactions with healthcare professionals due to a high BMI, even though it was due to increased muscle mass and not fat. Besides that, the relationship between BMI and body composition varies across different ethnic groups, such as Asian, Middle Eastern, and Black African populations, potentially leading to inaccurate assessment of obesity and potential health risks.
So the concerns that both of you mentioned have also been the topic of position statements by many associations. Dr. Almandoz, could you tell us about this statement from the American Medical Association regarding BMI?
Of course. In 2023, the AMA issued a statement highlighting several important limitations of using BMI. Specifically, they acknowledge that, and I quote, "The significant limitations and potential harms associated with the widespread use of BMI in clinical settings and supports its use only in a limited screening capacity when used in conjunction with more valid measures of health and wellness." The AMA also recognized that, and I quote, "BMI does not appropriately represent racial and ethnic minorities, and that BMI cutoffs are based on the imagined ideal Caucasian and does not consider a person's gender or ethnicity." To address these limitations, the AMA recommended that BMI be used in conjunction with other measurements, including, but not limited to, visceral fat, body adiposity index, body composition, relative fat mass, waist circumference, and genetic or metabolic factors.
That is to say, the AMA is encouraging a more comprehensive, patient-centered approach, similar to the 2023 statement on BMI from the International Obesity Collaborative. Dr. Ard, can you tell us about that statement?
Sure. In their statement, the International Obesity Collaborative describes BMI as, quote, a measure used to screen for obesity that neither defines the disease nor replaces clinical judgment, end quote. The IOC also highlighted that factors like, quote, social determinants, race, ethnicity, and age can modify the risk associated with a given BMI, end quote. Essentially, BMI can't tell the whole story. According to the IOC, the success of obesity management should not be measured solely by changes in BMI. Instead, it should focus on weight and health goals determined collaboratively by the patient and their healthcare professional.
So, what are some of the other valid measurements of risk that can be used to get a bigger picture than using just BMI?
One major area of focus has been measurements based on waist circumference or body shape, like waist circumference and waist-to-hip ratios. These measures are more accurate at capturing fat distribution compared to BMI, as they give us a clearer sense of central or visceral adiposity. So, in practice, we've been using multiple traditional measurements individually to get a more complete picture of weight-related health risks. These include height, weight, BMI, waist circumference, and hip circumference. By addressing these measurements separately, we are addressing some of the limitations of BMI and gaining a more accurate understanding of our patients' individual weight and health risk. However, despite their potential to predict metabolic and cardiometabolic risk and their quick, low-cost nature, waist circumference and waist-to-hip ratio are not without their own set of practical challenges. They are not always used in clinical practice due to the difficulty of obtaining reliable measurements without trained staff. Dual energy X-ray absorptiometry, or DEXA scanning, CT scan, and MRI can all be used to characterize body fat distribution, including visceral fat. They are accurate but costly and, again, require trained personnel to administer the assessment. DEXA and CT scans also involve radiation exposure. The Body Roundness Index, BRI, is another measure that uses height, weight, and waist circumference to calculate a score. It's a quick and low-cost assessment designed to estimate body roundness and fat percentages. Because BRI includes waist circumference, it may offer some insights into visceral fat distribution. Bioelectrical impedance analysis, also known as bioimpedance, is a method that is gaining popularity for assessing body composition in clinical practice. It works by measuring how easily a weak electrical current flows through the body. Because different tissues in the body have varying conductivity, the measured electrical resistance or impedance can be used to estimate body composition parameters, including fat mass, muscle mass, and body water. These estimates are then used to calculate fat mass percentage. While not perfectly accurate, bioimpedance can be a useful clinical tool for characterizing body composition in routine care. However, bioimpedance accuracy can be affected by testing conditions such as hydration levels, which can be a source of inaccuracies. Nevertheless, bioimpedance is becoming increasingly common in primary care offices, especially those focused on obesity care. Many offices at our center have this equipment available because it's such a practical and widely used tool.
Dr. Ard, what do you see as the next big advancement in obesity assessment after BMI?
I agree with all the options that Jamy mentioned. I want to add, though, that since consistency in measuring waist circumference in clinical settings has proved to be challenging, I believe technology can offer an accessible, valid, reproducible solution. Digital anthropometry advances have the potential to improve consistency and ease of measurement and provide patients and clinicians with more reproducible, actionable information. These underutilized developments offer promising new directions in how we assess body composition and estimate body fat and lean mass. For example, even simple phone-based apps using camera technology may soon be able to provide body fat composition estimates and track patient progress over time. Such apps using readily available smartphone cameras can capture images and, through cloud-based analysis, quickly estimate total and abdominal fat mass. Beyond simply providing numbers, digital images can also help patients visualize changes in body shape, which may be more motivating than numerical data alone. While further research is needed to validate the link between body shape and cardiometabolic health risk across different populations, I am excited to see what this technology holds for improving obesity assessment and management.
Thank you both for joining me today to discuss the pros and cons of BMI as the primary screening tool for obesity. While BMI is fast and easy and is a widely used measurement, it may not provide the full picture of a patient's overall weight and health. And adding other anthropometric measurements like the ones we discussed may provide more reliable information on our patients' weight-related health risks and prognosis. To truly improve patient care, we need these additional tools that go beyond BMI to give us a more accurate and comprehensive assessment. Dr. Ard, Dr. Almandoz, do you have any closing remarks?
Bob, thanks for having me on the podcast. It's always a pleasure to discuss these topics with you. I agree that we now understand the use and limitations of BMI, and we're looking for ways to improve our clinical practice. We need to augment the information we get from BMI with additional metrics for a more complete picture of patients' weight and health.
Bob, thank you for having me on the podcast. I've truly enjoyed our discussion. Today, we've explored why BMI is a widely used measure for assessing weight and health risk. I will add to what Jamy said. To truly advance obesity care, we must embrace a more individualized, evidence-based approach, one that considers metabolic health complications and the lived experiences of patients. By shifting our focus to comprehensive clinical assessments, we can improve diagnosis, management, and outcomes for people living with obesity. Thanks again.
Thank you both for such a great discussion. This concludes this episode of Moving Toward Better Metrics, Can We Do Better Than BMI? Please join us for the next episode of Obesity Chronicles, A Novel Perspective. For more information, please visit rethinkobesity.com. Novonordisk is a registered trademark of Novonordisk AS. All other trademarks, registered or unregistered, are the property of their respective owners. Copyright 2025 Novonordisk, all rights reserved. US 24 OB 00624, June 2025.